Yeah, good evening, ma'am. Myself, Dr. Seema Partani from Geetanjali Medical College, and my team partner is Dr. Naveen Patidar, and our mentor is Dr. Seema. Next, please. So, I am going to present this case. She is a 88-year-old female with age-related hearing loss, presented with decreased appetite, cough, poor oral intake, and deterioration in her general condition since 2 weeks. She is having increased drowsiness, decreased interest in her surroundings, and fecal and urinary incontinence since 2 to 3 days. She is more alert in the daytime, but increasingly drowsy towards the evening. And she is having comorbid conditions like diabetes mellitus, hypertension, major depressive episodes, atrial fibrillation, and there is history of ischemic cerebrovascular accident in 2012 and 15. And in 2015, pacemaker was implanted. There is no history of dementia or any cognitive impairment. She is on multiple drugs like amiodarone 200 milligram, losartan 50 milligram, rivaroxaban 15 mg, escitalopram 10 mg, and pantoprazole and an antibiotic medication. Next, please. On physical examination, she is arousable, but there's decreased psychomotor activity. She is not oriented to time, place. Muscle strength is 2 by 5 in right lower extremity and 3 by 5 in right upper extremity. On auscultation, she is having crepitations in left lung, left lower lobes. On investigations, the leukocyte counts, the blood investigation 8,700, hemoglobin 9.5 gram per dl, platelet count is 3 lakhs 14,000, urea is 68, slightly raised, creatinine is 1.4, and creatinine clearance is 33 ml per minute. CRP is 69 milligram per liter, electrolytes are within normal limit, ECG is normal, and pulmonary infiltrates in the left lower lobe on chest X-ray. RBS is 139 milligram per dl and HB1AC is 5.8%. Next, please. Predisposing factors having high vulnerability in this case: advanced age, frail, sensory impairment. She is hard of hearing, and she is on multiple drugs of polypharmacy, multiple comorbid conditions, and reduced oral intake. And some noxious insults, like some trigger precipitating factors in this: the aspiration pneumonia, maybe dehydration, acute renal failure. Next, please. Assessment by the history, and very important is confusion assessment method in this case. In this, we are going to we ask some questions to the patient. We ask the patient to the about the mental status in last 24 hours. Any change in the mental status in last 24 hours, and ask the patient to tell about the days of the week backwards, like Saturday, Friday, Thursday, like this. In local language, we can ask to the patient, or we can give some random numbers or random words to the patient, and after 5 minutes ask to repeat that in backwards. So whether she can, this shows the orientation, attention towards the this her situation. Then we can ask like for the orientation ki kya din hai, kahan ho. We can ask for the place and year and some questionnaire. And while communication with the patient and during confusion assessment method, we should look for the speech of the patient, the language, the whether it's rambling, verbose, the speech tangential, or was the patient's flow of ideas illogical. So these are the, basically it is a 9 questionnaire method, this confusion assessment method, and this is very important to diagnose patient, to differentiate also whether it's delirium or dementia or whatever. And another is based on the this DMS 5 criteria. That is, the first is acute onset and fluctuating manner of the disease. Second is the disturbance in the attention of the patient. And third is there is disorganized thinking. There is some impairment in cognition, like memory impairment, disorientation. And the last fourth one is there is altered level of consciousness of the patient. And fifth is again to to find out the cause based on the history, physical examination, everything, whether this delirium is because of the some already existing medical conditions. So this is to rule out the cause. This is the fifth. So to diagnose the case of this delirium, there should be the criteria 1 and 2 should be there, and out of 3 or 4 there should be one, either 3 or 4 along with 1 and 2. So this is to diagnose the case of the delirium. So these are the two methods which we used: confusion assessment method and the DMS-5 criteria. Next, please. To manage this case, it's a multi-component intervention. Most important is correct the correctables. If there is infection, start IV antibiotics, dehydration, fluid replacement therapy, and patients is already if diabetic, so just look for the glycemic control and start any oral this anti-diabetic therapy, regular glucose monitoring, parenteral feeding, and it's very important hearing aid. So because she's hard of hearing, so by providing her her hearing aid was at home, so we asked her, this caretaker, to bring the hearing aid, wheelchair mobilization to change the orientation, to change the situation, then medications given by 9 o'clock. It's very important so that the patient not woken up at the night for monitoring or for the medications. So good sleep should be there, and familiar staff taking care should be there. Next, please. On day 2, there was a decrease in the acute phase reactants and decrease in the creatinine level to the baseline. On day 3 to 5, sleep was improved. There was improvement in the appetite and the oral intake. She was well oriented to time, place, and person, and patient was discharged home. Next, please. So this is all about the basic history and management of the this case. And now I please Dr. Seema will take over.
Yeah, thank you, Seema. Um, uh,
Thank you, ma'am.
yeah, thank you, Seema, for presenting this case. This is ideally a sort of a case that we come across normally in most of our practice, where there's a lot of overlap between symptoms, and diagnosis of delirium becomes very difficult. So what I thought, once she has presented the case, we'll take you through the evidence base that is available for the management of delirium. As you know, one of the most important or the difficult things is to actually identify and delirium, though it is very common in palliative care. More than Towards the end of life, more than 88% of patients have delirium, but regularly it is underdiagnosed and undertreated. So we have to be very aware, and I thought I'll discuss it into three aspects: when do we suspect delirium, how to spot it, and how to stop it based on the evidence that is available. uh, just click next. Yeah, so when do we suspect? As you have seen in this case, there are certain predisposing factors which are non-modifiable. It could be due to the individualistic, due to the person, like elderly, or it could be due to poor nutrition. Um, and on top of it, these factors are non-modifiable. You cannot change it. On top of it, there is some precipitating factor that happens, like in this 88-year-old lady with sensory impairment, where the predisposing factors, the lower respiratory tract infection that set in, was a precipitating factor that led to the development of symptoms. So first of all, we should know what are the predisposing factors, what are the precipitating factors, and who are more susceptible to develop delirium, so that we can um, stop it. Next, click done. Yeah. And one of the I am how do we diagnose it? A detailed history is extremely important, and astute clinical observation. And there are a lot of tools, delirium screening tools, that are available for use. The diagnosis is basically DSM-5 or ICD-10 criteria is the gold standard for diagnosing delirium. It's also important to plan management, to know what is the subtype of the delirium and the severity of the delirium also, which we'll again discuss later on. And click next slide. Yeah. And then we have to assess and manage the delirium depending upon our patient's physical performance status and the treatment goals that is there, especially in palliative care. And the treatment involves preventing the development of the delirium and treating it through non-pharmacological as well as pharmacological means. Next slide. So as we can see, as I said before, there are these predisposing factors which are not modifiable, which are there in the individual. Whenever we notice the predisposing factors, it should be the red line and we should be alerted that we have to manage delirium. Precipitating factors in are the causes of delirium that we see. I think eye watch death is the mnemonic that is there. There are multiple precipitating factors that can occur in palliative care. It could be dehydration, it could be electrolyte imbalances, it could be infection, it could be any encephalopathies that set in. And most importantly, one of the commonest causes is iatrogenic, that is medications. And especially in palliative care, benzodiazepines, corticosteroids, and opioids are independent factors that can cause delirium in palliative care. Next slide. So once we know the predisposing factors, these are the patients who are at risk to develop delirium. We need to identify these patients, whether it is in the hospital setting or whether they are at home. And keep assessing. If they are in a hospital setting, then we need to assess these patients every 24 hours or so to see if they are developing delirium. If they are at home, educate and inform caregivers about the signs and symptoms and what to watch for. I have listed the tools that are available. This was published in 2012, I think, in the World Journal of Psychiatry. The various assessment scales for delirium was looked at. To assess etiology and risk factor, you have delirium etiology checklist. Screening instruments are multiple, but one that has been regularly used in palliative care mostly is the nursing delirium screening checklist. The diagnostic instrument, though the gold standard for diagnosis is DSM-5 and ICD-10 criteria, psychiatric examining the patient and diagnosing based on the DSM-5 ICD criteria. But confusional assessment method is a good tool that has been used, widely used in palliative care and in patients with medical illness, both for screening as well as diagnosing delirium. It's got high sensitivity and specificity. It's a 9-item questionnaire, and it looks at the 4 features. That is the acute and fluctuating onset, the attention, disorganized thinking, and altered level of consciousness. It looks at all this to diagnose delirium, and it is concordant with the DSM-5 criteria for delirium. So this is one tool that can be used both to screen as well as to diagnose. To look at the severity of delirium, Memorial delirium assessment scale is an instrument that can be used, which looks at the severity of the delirium. Cognitive symptoms, we can look at mini mental status examination, and there is a delirium motor checklist to look for motor symptoms of delirium. So we know delirium can be of 3 types. It could be hyperactive, hypoactive, or mixed, and the motor checklist looks primarily at the motor symptoms of the delirium. So these are the common tools that have enough evidence for use. And next slide, please. Yeah, and this is the DSM-5 and ICD-10 criteria for delirium. As you can see, there is impairment in consciousness and attention, which is one of the criteria. There is a global disturbance in cognition, disturbance in sleep-wake cycle, emotional disturbance. These are all that are listed as the to make a diagnosis of delirium. Next slide. So how do we, once we have suspected delirium in a particular group of individuals, we know what the precipitating factors are. We have screened and diagnosed delirium. Then how do we proceed with stopping it? What are the non-pharmacological interventions that have evidence for treatment? We know the evidence shows that there are multiple factors that are responsible for delirium. A single patient may have more than 3 factors that leads to delirium. Just like this lady who had an infection, on top of it she had dehydration, 88-year-old with a sensory impairment. So there are multiple factors that can contribute to a delirium. Since there are, it is multifactorial, the management is also multi-component. So you can have environmental manipulation. You need to place the patient, if they are getting admitted into the hospital, ensure that they are placed next to a window where they can see out. There is sufficient ventilation and sufficient light in the room. There is not too much of sensory stimulation that occurs, not too much of noise. Ensure there are orientation protocols in place. There is a calendar, there is a clock that lets the patient know the time, the date. Stimulate the patient cognitively, keep them aware of what is happening around them, what the time is, the date is. So ensure that there are regular familiar people visiting the patient, so that it does not contribute to too much of confusion. And as Seema said before, facilitation of physiological sleep, not disturbing the patient during the night times, is extremely important. And as early mobilization of the patients as soon as possible, and avoiding use of physical restraints. These can cause more confusion. We will discuss in it, other than physical restraints, how can we control the patients? We'll discuss it later. And of course, if there is a sensory impairment, ensure that this patient has the visual or hearing aids that is needed, so that it does not add to the confusion. Adequate hydration is extremely important. And what we call as deprescribing. Sometimes one of the commonest cause of delirium in palliative care is polypharmacy, or the multiple medications that are used. And so sometimes we may have to deprescribe. Um, and also it is very important to train the caregivers, whether it is the nurses or the professional caregivers or the family caregivers, in what all needs to be done to mitigate the risk of this patient developing delirium. Next slide. So this is how do we assess which drugs are likely to cause delirium? This was a paper that was published in 2016, which looked at the delirogenic potential of the pharmacological drugs that are commonly used, and which drugs, when withdrawn, can precipitate delirium. They divided, it is called as the Delphine score. So drugs with a Delphine score of 0 were not likely to cause delirium at all. With the score of 1, they are responsible. They can lead to delirium, and those with the, like that, with the score of 3 are likely, more likely to cause delirium. So they divided like this. Let's see what are those drugs. Next slide. Yeah. So these are the drugs that can cause, they've divided the drugs into different categories. If you can see the Delphine score 3, these are anticholinergic drugs which are likely to cause delirium. And withdrawal, on to the right, there is the Delphine score of substance withdrawal. Withdrawal of benzodiazepines and opioids also can precipitate delirium. If you look at these drugs that I have marked in red, you can see Delphine score 2. One of the drugs that we commonly use, that is alprazolam and clonazepam, are, the are also have a Delphine score of 2. That is, they are at an increased risk of precipitating delirium in susceptible individuals. Most importantly, if you can see, if you come down that list, you see olanzapine also there. Olanzapine is a antipsychotic that we use in the treatment of delirium. But olanzapine can also cause, it also has anticholinergic properties. And if you can see, it has muscarinic activity. And at 5 milligram, almost 13 to 57% of these receptors are occupied. But any dose more than 5 milligram, the occupancy goes up to 90%. And when we increase the dosage, this can result in anticholinergic property and result in delirium. If you come on to the left side, you can see Delphine score 1. Here you have haloperidol, lorazepam, midazolam, which are least likely to cause delirium. So looking at the Delphine score, we can, choosing antipsychotics and drugs to treat, we can look at these scores before we look at, whenever we start drugs, we need to look at these score and know that these drugs can precipitate delirium and educate the caregivers. Next slide. So, what is the evidence that is there for this multi-component, multimodal management of delirium? There is a moderate quality evidence for the clinical effectiveness of this intervention. Non-pharmacological management can shorten the duration of delirium. It leads to improved health-related quality of life, but there is no evidence to suggest that it shortens length of hospital stay, it improves cognitive impairment, or that it has any effect on mortality. So the recommendation is that this should be the first line of management for all patients with delirium. But it becomes the second line for those who are highly agitated. These interventions may not work. Next slide. Okay, so coming to the next thing, when do we use pharmacological management? And among the antipsychotics, is there any one drug that is more effective than others? Let us look at the evidence that is there for that. Next slide. Okay, so one of the first things that we have to assess when we look to start a pharmacological agent is to find out, is the patient at risk to himself or to others? Is there a chance that this patient is so agitated that he can harm himself or cause harm to the others around? So if there is a that risk is there, we need to use what we call as verbal and non-verbal de-escalation techniques. Reassure the patient, have a non-confrontational communication, bring a familiar person into the picture. It could be a familiar healthcare provider or it could be a family member. Do not use any restrictive techniques like tying up the patient, shouting at the patient, or to try to control the patient. This can again precipitate the confusion, or even can precipitate violence in that individual. So there are certain protocols that are there, which generally the psychiatrist or the nurses who are trained in psychological issues can are trained how to handle these patients, and you try to de-escalate the confusion or the agitation in the patient. If de-escalation is unsuccessful, then you consider the use of antipsychotics, the lowest dose for the shortest period of time. Next slide. So what are the medications that are available with us for the management of delirium? So I have only listed the antipsychotics that we normally use here. So one of them is the typical antipsychotics that we generally use, haloperidol. And then there are the atypical antipsychotics like olanzapine and qutipin. And then, of course, we use benzodiazepines. And among the benzodiazepines, we have clonazepam, lorazepam, midazolam that we normally use. Haloperidol has got D2 activity, alpha-1 activity, H1 antagonism. It has weak 5-HT2A activity. It's a weak anticholinergic. Olanzapine, in addition to D2 and 5-HT2A, has significant activity on the muscarinic receptors, and that is that anticholinergic activity is there. And qutipin also acts primarily on the D2 and 5-HT2A and are good antipsychotics to control agitation. Next slide. Okay, so there has been a lot of controversy about the use of antipsychotics in the use of for delirium. There is little evidence for use of the use of antipsychotics in delirium. There was one moderate quality RCT which indicated that there was decrease in duration and severity of the delirium. There was not much difference between antipsychotics. It more or less depended upon the side effect profile. So the recommendation in NICE states that antipsychotics have to be started only after correcting the correctable and multimodal interventions have been tried. It is meant only for those patients who are severely agitated or who have severe delirium. And they recommend the use of haloperidol for a shortest period of time, the lowest dose to be used. This, I think the controversy about starting antipsychotics for delirium in palliative care started with one RCT, which looked at around 200 and more than 200 patients, and it looked at haloperidol. What is it? Yeah, I will talk about how do we decide about treating, when to stop, when to start. I will come to that later. So this particular trial spoke about how difference between haloperidol, risperidone, and placebo, and it showed that patients who were on antipsychotics had increased extrapyramidal symptoms. Um had a shorter median survival, and the probability of death was 1.5 times greater in these individuals. So that is the reason why the controversy about starting using antipsychotics in delirium rose about. Next slide. Let us look at what the ESMO, next slide please. Okay, what were the ESMO guidelines that looks at adult cancer patients and the treatment of delirium in these patients? They recommend that administration of haloperidol and risperidone had no demonstrable benefit in the management of mild to moderate delirium. This was the RCT I spoke about. Haloperidol, in fact, worsened the delirium in the palliative care population. So what they suggested was administration of olanzapine, quetiapine, or aripiprazole for symptomatic relief, but there was insufficient evidence here. The ESMO also suggests methylphenidate may improve cognition in hypoactive delirium. Again, not a robust evidence for this. And benzodiazepines for acute management of severe distress. Again, insufficient evidence. So primarily, um, um, again, the same confusion results. Next slide. This was a recent um, paper that had come in July 2020 in the Lancet. They said that there was use of antipsychotics. Again, they looked at haloperidol and chlorpromazine. It had little effect on duration of delirium and delirium severity, but it helps in reducing agitation, especially in terminal delirium. And the dose of haloperidol that was used was higher, around 12 milligram. This was again said that haloperidol was beneficial in the management of severely agitated patients. Next slide. So finally, I looked at the PCF also, which said that though though there has been controversy about the use of haloperidol in mild to moderate delirium, in severe delirium, when there is chance of when agitation is there and patient is at a risk to themselves or to the others, then antipsychotics can be used. Among the antipsychotics, there are no specific choices. All have the same efficacy. It mostly depends upon the side effect profile. So when we look at haloperidol, starting at a dose of 0.5 to 1 mg, olanzapine 2.5 to 5 mg mean dose, and quetiapine 25 milligram. These are the doses that could be used for managing delirium in patients. Next slide. So when we choose, first of all, we need to look at age. The more elderly, the more chances of the side effect and the side effect profile of the antipsychotic that we are going to use. So in an elderly patient, it is better to go for an antipsychotic which has lower chance of causing extrapyramidal symptoms like quetiapine. Look at comorbidities. In dementia and Parkinsonism, you can look at atypical antipsychotic like either olanzapine or quetiapine. If patient has diabetes, then haloperidol, and hyperglycemia is a risk with atypical antipsychotics, both olanzapine as well as quetiapine. Then it is better to look at haloperidol. Organ dysfunction, we need to see what is the renal, if there is a renal dysfunction, then haloperidol would be a better drug to use. What is the subtype of delirium? If it is hyperactive, you need to control haloperidol. If it is hypoactive, atypical antipsychotics are better. In terminal delirium, a combination of an antipsychotic with the benzodiazepine works better. The side effect profile that we need to look at is whether extrapyramidal symptoms are a concern, whether cardiac issues are there, where there is a QTC prolongation, is there a risk for stroke, there is a chance of sudden cardiac death in these patients. These are all things that we need to keep in mind, and we need to choose based upon this. Next slide. So one of the newer things that the people have been talking about is dexmedetomidine in the treatment of hyperactive delirium at the end of life. This was one paper that was published in Palliative Medicine in 2021. So the indication for this was terminal delirium. The doses was from zero point 0.3 microgram per kg per hour. The patients were screened using the nursing delirium screening checklist for the RASPAL for the wakefulness and the MDAS for the severity of the delirium. Definitely, after starting this medication, there was a good response. The delirium MDAS scores came down, and the sedation was, patient was rousable. One of the things that was very good in this study was, though patients delirium came down and they were rousable, but still they were rousable. That were, whereas when we use a sedation with haloperidol or with midas, patients are continuously sedated throughout. So during end of life, this gives the patient a chance to communicate with the family when we use this. So this was one paper that has been published, something that we can look at for the future. Next slide. So finally, when we look at how to manage delirium, it's basically a balancing act that we need to do. What is the goal of management in this patient? Is the delirium reversible or not? Are we looking at a terminal delirium? So once we correct the correctable, the next step is, what if it is terminal delirium, what are we looking at? Are we looking at to relieve the symptoms? At the same time, we also have to maintain the patient's ability to communicate. So it's a balancing act between these two. And it also depends upon the values and quality of life of the patient and what are the goals of the caregivers. So based on this, the management of the delirium has to be done. So it's walking the tightrope between managing a distressing symptoms and causing the least harm as possible. So ideally, if it is mild to moderate delirium, that we look at non-pharmacological intervention and not start on any antipsychotics. If it is a severe patient is highly agitated, then we can choose from any of the antipsychotics that is available to us, whether it is haloperidol or whether it is qutipin or whether it is olanzapine. But while choosing olanzapine, as I said before, it is important, if the patient does not respond to 5 milligram, don't keep escalating the dose, because the anticholinergic effects can come in as we increase the dose and the dose goes higher. At the same time, if patient is not controlled on the antipsychotics, it is important to add on a benzodiazepine, preferably lorazepam, because it has the least delirogenic potential. And or midazolam for that matter. Between the two benzodiazepines, you can choose any one. And give it for the shortest duration of time. If it is a reversible cause, then give it for the shortest duration of time. If it is terminal delirium, then of course we need to continue this for a longer period of time or till the end of life. So that is how you manage. These are the what evidences are there in the management of delirium. Next slide. Yeah, thank you. So, Naveen sir, any comments from your side, sir?
I think you have explained everything, most of the things, and you are the expert uh, as a dual role of psychiatrist and a palliative care physician. I have nothing more to add. If there's any specific question that needs to be answered, I'm happy, but I think I don't have anything more to add. Yeah.
Cynthia ma'am? You're muted, ma'am.
I think delirium is such a difficult symptom for all of us. It's very, very challenging. And usually it happens in the background where the family is extremely upset. And so I think I'd like to ask the nurses about prevention, because I think the best thing is is to prevent delirium. And when we know that there are predisposing factors, we want to reduce the number of precipitating factors. So could I have some input from the nurses? I mean, any elderly person, particularly who's cognitively, I mean, who's deaf and who's or can't see very well, you move them to a strange surrounding. I mean, the precipitating factors are all there. What are your views? Who would like to start? Hanife, Gavindi, who else is here? Hanife, would you like to start?
I think one of the things that we can do easily, which we should do, is assessment. And this is also physical assessment. When they have like radiation, when they are post-radiation, when they are coming from different diagnosis earlier, because we don't know where these little infections happen. So we need to monitor these things so we can nip it from the beginning. This is number one. Number two, we need to talk to these people every single day. And when we see that they have some problems with behavior, some problems with communicating, we shouldn't say, oh, the old lady is confused. Old lady is not confused. We need to start talking. We need to also get a baseline, of course, when they are first admitted with proper assessment. Okay. And then the other thing is, I really think when these people are, as Dr. Sima said, we need to give them space. We need to give them time. And we also have to keep watching their psychomotor activities. Is there any retardation? And what is going on? These things happen fast. And when it does happen, and when we think there is delirium happening, then I think the nurses scale from 0 to 2, it has to be done every single day. It only has like 5 points, and every shift we need to do this and try to take control of things before everything gets worse. And reorientation, even when you see them in the morning, you see, just talking to them, asking them to say things, checking the date, the time. We don't have to do that when they're all confused. We have to do it before they are confused, before the delirium comes. That's all. There's more, but. Okay.
Thank you so much. Vidya?
Seema, really nothing to add. But when Sister Hanife was talking, I was just thinking that we have seen delirium in patients, which is again common with a full bladder. So they have retention, but no one really knows because they're so delirious, and especially in home care. So we actually tell caregivers that palpate and make sure they pass urine every day, and if not, let us know, because otherwise even on home care and on telephonic consults they just say he's behaving like that, but the delirium could be because of a full bladder. Also unrelieved pain, this is again another, delirium is another presentation. So like what sister was saying, preempting this, talking to the caregivers that these are things that can happen is also part of our anticipatory care plan and our regular consults.
So this is one of the precipitating factors, as we say, urinary retention, constipation, pain, all this can precipitate delirium in an individual who's already predisposed because of so that is what that slide that Dr. Seema showed with a patient with high vulnerability, even a small insignificant noxious insult can precipitate delirium. So in a elderly patient with multiple comorbidities who's very frail, just bladder metastatic, advanced metastatic cancer, nearing end of life, just even constipation or even urinary retention or a mild UTI can present as delirium. So that is something that's what I said, the predisposing and precipitating factors. These are two things that we need to keep in mind whenever we see anybody who has the predisposing factors. We need to educate the healthcare provider as well as the family that there is high chances that this individual can present with delirium. So yes.
Seema, would you like to talk to us about dosing of these neuroleptic drugs that you mentioned? Because what happens is, people start with a low dose, like 0.5 of haloperidol, then maybe twice a day, and then it doesn't work. So people will just keep on going up and going up. Now, how far should one go up for taking one drug, and when do you switch to another one?
So I think I didn't go in detail. I think if you can share that slide, there is a Tanyan, can you share the slide? I think drug dosing is there in that.
Okay,
Reshare the slide. I can.
give me a moment. Let me
Yeah.
open it up again.
Yeah. So the haloperidol, basically we might start with 0.25 mg and we can go up. The median dose, what is given in PCF, is anywhere between 0.25 mg up to 10 milligram. So if the patients don't respond, go next. I think it's one of the last slides. Yeah, that one. Yeah, this one. The 23rd slide. So if you can see here, we start with 1 milligram. You can go max 5 milligram per day. And the median dose that is seen is basically 1 to 20 milligram is what they have said. So that is the maximum dose that you could go in a day. If patients don't respond to this, either we can switch, add on a benzodiazepine, or we can switch the antipsychotic. When it comes to olanzapine, it is 2.5.
So sorry, Seema, can we just stick to haloperidol to start with? You know the paper that Mira Aga wrote about haloperidol, where she says that it actually makes delirium worse in higher doses. What sort of comments do you have on that? I mean, should we go? I mean, I've never gone up to 5 milligrams, really. I don't know when to stop and switch, in other words.
Yeah, so the recent paper that I have put up, Lancet Oncology, which has come in, which was done in the MD Anderson group had done it. They had given almost 12 milligram for severe delirium. So the paper that was there with the Mira Agar paper, which created the controversy about using antipsychotics in delirium. I think some of the criticisms that came with the paper was the most of the patients had mild to moderate delirium in that case. Plus, the second aspect was the cause of delirium was not clearly known, whether it was reversible or irreversible, and how was it distributed between the three groups of haloperidol, risperidone, and placebo. That was also not known. So that data was not very clear. So, and also, as we say, the mild to moderate delirium, the recommendation is not to give antipsychotics. It's only when we look at severe delirium and agitated delirium that we use antipsychotics. And anywhere up to 10, I think one of the things that was mentioned in that Lancet paper was that the reason why no effect was seen is probably because we were using lower doses of antipsychotics. So they had used around 12 milligram of haloperidol to get the effect. So I think the dosing up to 10 milligram is what is said, the median dose what is given in PCF. And in case they don't respond to that dose, you can always switch over to or add a benzodiazepine or switch over to another medication.
Do you find that in India, your patients, or maybe due to lower body weight, that the dosings is different? Can you give us,
yes.
What is your local experience?
Yeah, generally we have seen even with a small dose, sometimes they do develop side effects. So basically that should guide you. Rather than the efficacy, it is about the side effects. You see what are the side effects, and that should guide your dosing. If they are developing EPS, extrapyramidal symptoms, then it is better to switch over to an atypical antipsychotic like olanzapine or Qtipin. Um, so I think, and olanzapine, I think I told, the higher the dose, the more the anticholinergic effect. So that can worsen delirium, especially in the elderly. But again, olanzapine doses up to 10 milligram is what is discussed. You can go up to 10 milligram. Qtipin, I always feel we underdose there as far as Qtipin is concerned, because you can go up to 75 milligram. We start with 12.5, 25. We can go up to 75 milligram for delirium in palliative care with Qtipin. That is the dose. And of course, aripiprazole we don't use much, so nothing sort of, so not much studies is there on aripiprazole in terms of this.
I think we're a bit scared of Qtipin because of the QT prolongation.
Yeah.
That's always sort of pointed out to you. Say something about risperidone.
Risperidone, yes, risperidone is another drug that can be used, but it is somewhere midway between haloperidol and olanzapine as far as EPS is concerned, 0.5 to 1 milligram. But there is a lot of, compared to other atypical antipsychotics, it can cause side effects that are slightly higher. Hyperprolactinemia is much more common with risperidone also, and akathisia is pretty common. With the restlessness is very common, that can um, confound use of other antipsychotics. I mean, you may confuse it with increase in the delirium. So that is the reason why uh, you need to be careful. And Dr. Rajesh has written, if one drug, say haloperidol, suspecting in causing, haloperidol does not cause delirium. It has the least delirogenic potential. So what I was talking about was about olanzapine. So haloperidol does not cause delirium. It has the Delphine score is 1, that is least of the delirogenic potential it is. So I think that has to be cleared. So, anybody else is there? Dr. Mayank, anything from your side?
No, excellently covered, ma'am. Nothing much to add. Thank you.
You're muted, Seema.
Yeah, Dr. Latifa has written, I'm dealing with a patient having nocturnal delirium. Very difficult to manage as most of the daytime he is calm and quiet. My query is, should I use regular dose medications or PRN? Okay, so I think one of the common things about delirium, the diagnostic picture is acute onset and that fluctuating course, and people becoming more confused as the um, um, sundowning, what is called. One of the things that we need to look at is this patient, what is the age of this patient? Is he cognitively impaired? Or is there any sensory impairment that is adding on and causing delirium towards the end of the day? And rule out any correctable causes before we look at starting medications. Is there any cause that is contributing to the delirium? Like, whatever correctables have to be investigated. Look at the medications the patient is on. Is there anything that has been started that is he's taking in the evening that can worsen, like a benzodiazepine can worsen the delirium? You rule out that, and only then initiate non-pharmacological interventions. Only if that doesn't work, then do you think of starting a medication. I think that is the way to go there. Like, look at all the predisposing factors, precipitating factors, how much is this, what is correctable, and then non-pharmacological interventions. If all this is not working, only then you think of starting.
Okay, ma'am. Thank you, ma'am.
You can speak about management of terminal delirium. What is the current evidence? And
Okay. Would you like to speak
no,
in
no,
terms of palliative sedation?
if
Because I haven't.
because I'm sure you must have reviewed some evidence which is there. And
Yeah. So with the PCF, when I look through that, the thing is management looking at haloperidol and midazolam as, you know, the combination for the management, and then dexmedetomidine was one of the recent papers in 2021 which looked at management of terminal delirium with that. Those are the three papers that I looked at.
How common is terminal delirium? I mean, what I know culturally is that many of our patients want to be alert and communicating with the family until the very end. But what is the incidence of terminal delirium?
I think in palliative care patients quite high, isn't it? Yeah. But exact incidence probably I don't know, but we see those who are receiving end-of-life care in the ward setting, probably almost 80% of the patients who are receiving end-of-life care, we see some form of delirium.
So they say about more than 88% is something what I've read through. 88 to 90% of patients towards end of life, like, you know, is the what is the incidence that I have read, like in most of the books they say that incidence of terminal delirium. But again, it is very difficult to identify probably at that point in time. So it's a sort of.
Ma'am, we see it. In
Yeah,
fact, we
I
hear
think
about it very commonly too, because whenever we have patients or when we make calls that patients have died and we ask them how were the last couple of days, invariably they tell us, about that they were like give us instances to say that they were in delirium. So I think it's very, very common. I mean, from what we see and hear.
I think it's.
I agree to that. Okay.
Yes, Maya, you carry on.
Yeah. I just wanted to say I agree that the incidence seemed very high in palliative care population, particularly at end of life, because it's one of the most common reasons of initiating palliative sedation, apart from dyspnea. I think so. It's the most common cause of initiating palliative sedation. So we see it very commonly in patients who are approaching end of life in the wards, as Dr. Naveen has already mentioned.
Well, I think the diagnosis of delirium at the end of life is also, a little bit uncertain because, I mean, patients are very weak at that time and they fluctuate in the weakness. So they may be lucid at one stage and they may sleep a lot the rest of the time. So it's hard to say whether they're delirious or not because there are times when they are lucid and those lucid moments are extremely precious to the family. I mean, of course, we have families who keep on disturbing the patient to say, "Oh, say something, say that you're all right." But with but part of palliative care management is to say, at this stage, the patient may be very weak. They need a lot of rest, so you keep them company. They will surface from time to time. It's nice for them, good for them to know that someone they know and someone they care for is with them. And that's sort of part of the management. towards the end of life, rather than to say, oh, you know, get very distressed about it and let's put them to sleep with palliative sedation. Naveen, I don't know whether you want to start a little conversation about palliative sedation, how frequently it's done and what are the indications?
So three, basically, if you look at the literature, intractable pain, uncontrolled breathlessness, and severe form of delirium are the three major indications for palliative sedation. Yeah, and we do it more common for the third one, the delirium, probably, because they classically present at end of life, and breathlessness probably the least one, and pain probably. Although theoretically it is possible, but offering palliative sedation in the other two is less common. And delirium, because it's more common, patients are at end of life. So we do quite a bit of end of life care management, which includes probably some bit of palliative sedation. That what we do. And most of the patient, as Seema has mentioned, haloperidol and midas would do the trick. But probably at least once a month we use phenobarbital for managing delirium, and we start somewhere between 400 to 800 and go up to 1600 milligram. Yeah, and only twice in my probably entire practice we have used propofol for managing delirium. Yeah. For sedation, the other good option is levomepramazine. Unfortunately, that's not available in India. It's a much smoother drug than phenobarbital, so it's much better. That's what we use. Um, Depends from individual to individuals. I go haloperidol in palliative sedation up to 20 milligrams. And I've gone to midazolam up to 150 milligrams sometimes before I have moved to phenobarbital. So it depends. Sometimes I'm quicker in moving to phenobarb. Yeah. And if we are very sure that it's end of life and it's delirium and patient has very short expectancy, I quickly probably move to phenobarbital. Yeah. Phenobarbital probably provides the excellent results with regards to palliative sedation. Actually, really are sedated. So the breakthroughs that happens because of restlessness, the breakthrough restlessness is least with phenobarbital compared to others. Yeah.
I
Yeah.
must say, in my practice, we use very little palliative sedation. In fact, it's quite rare, you know, just a few times a year for the whole team. But I think that the important thing is the decision making shouldn't be a single clinician. I think it should be a team decision. Of course, consulting the family, consulting the patient, but importantly, you know, not a single clinician should sort of hold the rule. Propofol, we all think is the best drug, but we can't use it because it's not allowed outside of ICU in most of the hospitals that I'm aware of. So we can't use it out in the wards. We certainly can't use it at home. So we are left with the other ones. Midazolam is the one that we normally use intravenously. Yeah. Seema, do you want to? Yes, Hanife, please.
I want to say one little thing about delirium when it's not severe. As you said, patients are weak, they are tired, they are going in and out. Now, here we are talking about science and research and articles, but on the flip side of things, we really don't know what these people are seeing, where their mind is, you see? So trying to say, oh, he's getting delirious, he's getting agitated, maybe it's nice to kind of gently talking to them, you see, because they could be seeing things. People could be coming to visit them. And we need to acknowledge that before we go to the drug routine. I just wanted to mention that.
Yeah, I agree with you, because one of the things that it says is that, if the patient is agitated, the first try the de-escalation techniques. That's what I mentioned, reassurance and communicate. Have a familiar person around who's talking to them, whether it is a healthcare provider or if it is a family member. And once all this doesn't work, only then in an agitated verbal de-escalation, non-verbal de-escalation, and then only you move on to an anti pharmacotherapy after that. So
I think that should be our take-home message, really, because, I think at the end of life, people do see things. People see dead relatives. People see, some ghosts or gods that bring them to the next land. And, we call them hallucinations, but they are so common that it's almost reassuring to say that, he's thinking about death. That's why he's seeing his dead father, mother, sister, or whatever, and reassure everybody around, rather than to, reach for the haloperidol, because so much of it can be done by a calm presence, by a healthcare worker, and people who are familiar to the patient. I mean, if the relatives are not upset, the patient usually calms down. And so much of our intervention is with the family to say, it's okay. We see this commonly at this part of their lives. Patients are very weak. They will drop off to sleep and they will come up again. And because delirium is also, fluctuating like that. I'm not sure we need to make a medical diagnosis at that stage of life if death is very near. I feel that medicalization of death, of dying, is something that we are very much to be aware of, because dying is a natural process. We should not medicalize it more than it is necessary.
it's finding that balance.
I love those stones at the end of your talk, which is all about the balance. Yes. So thank you, everyone. I think we've run over time a little bit. Any last comments?
I think we should reflect on what you said. They were the most beautiful last words.
So shall we take a photograph? Yes, remember that dying is a natural process. We must remember that.
And in fact, when patients and relatives tell us that, then we actually tell them, see, yes, it's time. So it's an indicator for that conversation also, because we hear this all the time telephonically. So it's giving time to everyone, physician, caregiver, patient.
But we should start the conversation of this sort.
Yeah.
Not when they call and say patient is dying, but from the very beginning. So it eases things out towards the end.
Yeah.
And I think this is important. Anyway.
Yes. Thank you, everyone. Have you got your cameras on?